नमो भगवते वासुदेवाय धन्वन्तरे अमृतकलशहस्ताय सर्वामय विनाशनाय त्रैलोक्यनाथाय श्रीमहाविष्णवे नमः.
Good evening, everyone. We welcome each and every one of you. Before moving on to the session, let's welcome our eminent faculty, Dr. Rahul R. Nair. He took his BAMS from Vaidyanathan P.S. Warrior Ayurveda College, Kottakkal, and MD in Yoga Nidanam from Pariyaram Government Ayurveda College, Kannur. Currently working as Assistant Professor and Head, Department of Yoga Nidanam and Vigruti Vijnanam, Specialist Consultant at Teaching Hospital, Ashtangam Ayurveda Chikitsalayam, Palakkad. Senior Visiting Specialist, Sidaram Pharma Specialty Clinics, Palakkad, and Medilife Polyclinic, Kutanad. Worked as tutor in Department of Kriya Shariram, Amuda School of Ayurveda, Assistant Professor and Consultant, MVR Ayurveda Medical College, Kannur, Evaluator and Examiner for University of Kannur and Kerala University of Health Sciences Graduate Examinations. He tries to explore the vast potential of Ayurveda in providing solutions for spectrum diseases like cancer, autoimmunity, pulmonary and cardiac disorders. We honorably invite you, sir. The dais is yours.
Aerosols which can land in eyes, nose or mouth of another person within 1 meter. Some interesting facts. Before COVID-19, if you want to visit US or some other places, you have to mandatorily take flu shots, the vaccines. And a lot of people died prior to COVID-19 unnoticingly. We were not noticing that so much people were dying in Western countries due to a simple illness called the flu. That was very curious. But when COVID-19 came, that became a very headline that a lot of people are dying every day. In every year, when the season of flu happens or it passes through the Europe and the US, a lot of people happen to die. For example, a statistics which was taken by the Center for Disease Control between October 2019 and April 2020, there are 39 billion to 56 billion flu cases was there in US, and out of them 24,000 to 64,000 flu-related deaths were reported in US up to April 2020, a period from October 2018 to April 2020. So that much deaths were happening every time. That points to the fact that the unlimited consumerism, the unlimited use of antibiotics and other medicines, highly technocentric medications, focusing more on guest factors rather than strengthening the host factors, all these were leading to such a great amount of deaths every year in such countries, even though they maintain a high culture of sanitation, hygiene, everything when compared to countries like us. In Kerala, in India, in 2018, almost 6,371 cases of influenza were reported and 226 deaths were there. And in India, the pattern of influenza is commonly the H1N1. Spreads mostly by respiratory route, multiplies in cells lining the respiratory tract. Cells undergo necrosis, love away. Mucosa will be hyperemic and edematous. Pneumonia, primarily viral or secondary bacterial, may ensue and death may occur anytime. The clinical features will be onset of sudden fever, myalgia, and non-productive cough. See, a fever, myalgia, non-productive cough, all those point to simple Vata Kapha Jwara. So how the people are dying? because of pneumonia, which is happening in between, especially to those persons who are immunocompromised, who are having long-standing debilitating illness, who are on the support of certain medications to prolong their life. So all those people will be affected due to pneumonia, and it is very difficult to bring them back to their life, even if a virus as low in potential as influenza attack happens. So the complications will be primary influenza virus pneumonia, which is having high mortality, high fever, cough with the blood-stained expectoration, dyspnea, cyanosis. These are the clinical features. Very seriously affecting, especially for those with the prior history of myocardial infarction, COPD, or rheumatic heart disease. There is high mortality due to primary influenza virus pneumonia. Influenza pneumonia with a secondary bacterial infection, it is another type. There will be more chances of consolidation here. Bacterial pneumonia caused especially by staphylococci, streptococci, pneumococci, and Haemophilus influenzae. Also, it is also having grave prognosis for those with the debilitating illness. And there is another term called coryza. Coryza and flu. It is different because nasal symptoms are more in coryza, less prominently seen in influenza. Adenovirus infection creates more sore throat and pharyngitis. Another term is streptococcal pharyngitis. It is giving more sore throat, cervical adenitis, and neutrophilic leukocytosis. So if you see cervical lymphadenopathy, neutrophilic leukocytosis is seen instead of neutropenia, which is usually seen in viral infection. But it is presenting like the influenza. More chance is, if there is a sore throat, more chances it is a streptococcal, it's a bacterial pharyngitis. So differentiating between bacterial and viral component by using this type of approach. And now I am going to deal with the Ayurvedic approach of influenza along with pneumonia, because both can be done concurrently. So community acquired pneumonia is a very huge problem, where pneumonia, a patient is declared as having community acquired pneumonia if he is having pneumonia. That person is outside long-term hospitalization or within 48 hours of hospitalization. So it differentiates from a person who got pneumonia from a hospital setting. This happens to be important because the pattern of organism which is creating a hospital acquired pneumonia is different from community acquired pneumonia. Pneumonia happens when there is a defect in pulmonary defense mechanism or a failure in pulmonary defense mechanism like mucociliary clearance, cough reflex, or immune response. If these systems will fail in patients with a long-standing pulmonary diseases, rheumatic heart diseases, previous history of myocardial infarction. So, in such cases, the failure will result in pneumonia. We hear this term pneumonia many a time now because when COVID-19 induced pneumonia is very common nowadays. So, in COVID-19 cases also, the situation is similar, wherein COVID-19 results in a situation, an ecosystem where the body has to defend itself by using these reflex mechanisms like a cough reflex. It has to step up the immune response of the body, or just to enhance the mucociliary clearance so that the organisms may not gain an entry into the lower respiratory tract. But what happens is, if you are a person with a long-term medication history, especially with allopathic medicines, and also who are immunocompromised, non-exercising, obese patients who are having long-standing lifestyle-related disorders, your body is not capable of stepping up these responses, and hence the organism may gain access to the deepest recesses of the body, especially the lower respiratory tract. So in that way, pneumonia will happen. And the bacterial causes are, just for the information, I am mentioning this here: Streptococcus, Haemophilus, Mycobacterium pneumoniae, Clostridium pneumoniae, Klebsiella pneumoniae, Staphylococcus aureus. All these can cause pneumonia. Influenza virus, respiratory syncytial virus, adenovirus, parainfluenza virus cause viral pneumonia. And the fungal causes are also there. Never think that this pneumonia is a bacterial disease alone. Histoplasma, blastomyces, coccidioids, all these can result in fungal pneumonia. The usual clinical features are fever, cough with or without sputum, dyspnea, sweats, chills and rigors, chest discomfort, myalgia, headache, abdominal pain, anorexia, hemoptysis, fatigue. All these are the usual clinical features of pneumonia. And the physical findings are fever, tachycardia, tachypnea. So remember that if you are admitting a patient with such symptoms or managing a patient with such symptoms in an OPD setting, and you can see that if the patient is presenting with a tachycardia or tachypnea or arterial oxygen desaturation, you are hearing bronchial breath sounds in areas where you have to hear the normal breath sounds like vesicular breath sounds. There is an alteration of breath sound pattern. Then you can be sure that the patient is getting into pneumonia. So auscultation is a must when you manage a patient with a respiratory associated infection. Auscultation is a must. So practice auscultation very well. A lot of information is available in the net. Also, you can refresh the old clinical methods textbook. So we will be getting a good idea regarding how to catch these sounds, and that can be equated with the change in infection pattern. And the lab and imaging panel will also help you. If you go for sputum culture, you can identify the organism. Also, for us, more help is we are not interested in finding out which organism. Instead, we want to know how the body is performing. So we are doing CBC with a differential panel, serum glucose level, electrolyte level, RFT, LFT. See, while doing LFT, if we see that SGOT, SGPT is rising very fast, one thing is very sure, that Dhatu Bhagam is happening in the liver. Liver cells are getting destroyed. The kidney cells are getting destroyed. Urea, creatinine values are increasing. Kleda Bhava is increasing in the body. So when taking an X-ray, chest X-ray, pulmonary opacity or chest CT finding showing a pulmonary opacity ranging from patchy airspace opacities to consolidations, pleural effusions or cavitations, another thing comes to our mind. There is an appearance of this patient with the Shadagasa, wherein in our textbook, Shadagasa is caused due to Yuthadehi Sahasehi. But here, the micro trauma is happened to our chest due to an infection. That can also be taken in the same way as that of Shadagasa. There, Acharya says that Kramad Viryam Ruji Paktir Balam Varnascha Hiyade. The patient is getting slowly deteriorated and succumbing to death. So such pattern, Shinasya Sasrang Mutratvam, Syacha Prishtakadi Graha, Sasrang Mutratvam, correlate it with the RFT pattern you might be seeing. So Kshadagasa comes into forefront. The Jwara was there, Kasa was there. Slowly the Kasa progresses from Vadi Kasa slowly into the Kshadagasa pattern. And when Kshadagasa comes into forefront, it can slowly deteriorate the status, and it can lead to death of the patient. So, such an approach shall be kept in our mind while we manage people with respiratory infections. And another type of pneumonia which we used to hear is nosocomial pneumonia, which is of three types, that is HAP, hospital acquired pneumonia, which is when the patient is getting infected from a hospital. Ventilator associated pneumonia, it is due to different species, which is due to certain procedures like endotracheal intubation or ventilator, which is associated with the body, and healthcare associated pneumonia, which happens to some persons who are in the community but who is associated with the healthcare, especially the persons who are in contact with the patients who is lying inside an ICU. They can get this HCAP. See, the mortality rate is 20 to 50% in hospital acquired pneumonia. Another theory which is coming around this HCAP is the long-term use of antacids. The PPA, that is proton pump inhibitors, H2 receptor antagonist. All these may change the gastric microbial pattern. So there will be gram-negative microbial overgrowth and tracheobronchial colonization may happen that result in HCAP. So if a patient who will be coming to you with the signs of pneumonia, it is necessarily to question the drug pattern of that particular patient. If he or she has been advised with such medicines which are having such property. This is a new theory, that is elevation in gastric pH leading to pattern of change in microbial growth, leading to tracheobronchial colonization and onset of pneumonia. This pneumonia may turn fatal to a very elderly person. So we have to step down those medicines, add our medicines to reduce the, which is having an antacid property, or reduce the Samapitta, and thus help the patient. So while dealing with such cases, another thing also come to our mind. Urastaha kuride shvasam amashaya samudbhavam. So all these entities, Jwara or Kasa, Swasa, all these having an inherent connection with the Amashya. So here also in Amashayam something is happening. The response we are seeing in Uras. So the connection between Uras and Amashayam is very prominent when we deal with the HCAP, hospital or healthcare associated pneumonia. And then comes the third one is anaerobic pneumonia. There is history of aspiration. This anaerobic pneumonia is otherwise known as aspiration pneumonia. This is very important when we go for palliative care patient, getting into a palliative care. So we will be visiting a palliative care facility or to a house where a person is lying under palliative care supervision. The patient may be depressed level of consciousness, may be having repeated seizures, may a patient under general anesthesia, impaired deglutition, those with nasogastric tubes, or a patient who is cachectic, long-term crippled into the bed. When we visit them, sometimes they will be telling us an insidious onset of symptoms. Lung abscess may happen when medical attention is sought. So a dramatic onset of symptom may happen. Gradually, the patient will be developing pneumonia. The essential thing is that we have to ensure that for such patients, feeding should happen in a sitting position only, so that a level of aspiration can be prevented. Another thing is maintenance of oral hygiene. This happens when the patient is having a very bad oral hygiene with lot of anaerobic organisms residing in the mouth, and there is a very chance of those organisms shifting into the lung cavity because of aspiration. And the patient being a bedridden case, he is having fever, attending fever along with the weight loss, malaise, etc. Several or anaerobic species like Fusobacterium, Streptococcus, Prevotella, bacteroids, all these may be the cause of this pneumonia. And there will be cough with the foul-smelling purulent sputum. So the foul-smelling sputum is pointing towards the presence of anaerobic bacteria that may cause an empyema. Empyema means the presence of pus in the pleural cavity, or that can create a well-defined lung abscess if you take a chest X-ray. So a well-defined lung abscess or an empyema, that all point towards an aspiration pneumonia. So this is very common in case of palliative care settings. Previously, I have once read about a practice which was prevalent in Tamil Nadu, wherein a patient who is long time bedridden, that patient having no hope of recovering back to life, then the people in the house will decide together in one particular day, they will give a very good oil bath to the patient, especially to the head and also to the entire body, and place the patient outside in the sun for some time, and then giving him a head bath. and likewise with the cold water. The practice was called Tadail Kutu. And at that time, after 2 or 3 days, the patient will start cough, productive cough, purulent sputum, fever, and gradually the patient may succumb to pneumonia. This has been banned by the court. I think the Honorable High Court has banned this practice. So this is a process. And also, we might have heard of a certain very respectful public figures who have been admitted to the hospitals, ICUs, for a long time due to different diseases, especially due to some other systemic disorders, due to gastrointestinal illness or neurological illness. Later, the death reports or the press reports by the hospital will be telling that the patient have succumbed, the patient have developed a pneumonia for 2 days. He is in active interventions. Yet, after 2 or 3 days, the patient was found to be succumbing to life. So, think about the community acute pneumonia, the hospital acute pneumonia, nosocomial infections, all this leading to the ending of life due to pneumonia. So, what I want to say that in our textbook, Acharya was telling that Sarvebi Roga Nashaya, Natu Evam Shikra Garina. Natu evam shikra garina, like Shwasa and Kasa, Shwasa and Hitma. So, Shwasa and Hitma were given a designation that they are Mrityugale Krudalayo. They will make the body of the patient their abode at the time of his death. So, such type of Shwasa which is having. So, one of the characteristic feature of this pneumonia is dyspnea. So, the evolution of dyspnea along with the fever, such factors will point to an imminent death of the patient. So we have to manage such patients in an aggressive mode. Ayurvedic approach of influenza and pneumonia. I am not going to speak about some clinical entities like Shosanaga Jwaram, some terms Shosanagam or Kante Kubjam, etc. Because even though such entities have been named, have been detailedly described, the selection of medicines were dependent upon the doshic status as well as the avastha of the patient. So it starts typically as a Vada Kapha Jwara, proceeds as such and end in majority. That means it can recover back if we are giving proper care. And beware of the complicating type when it proceeds to Sanibhadika Jwara. Resist dosha paga due to inherent weakness of Agni. Dhatupaga ensues, affection of Hridaya Marma and Uterus succumbs. Here, we can add one more point that the Samprapti may proceed from the Jwara, then it may proceed into Shwasa, it may proceed into Kasa, especially Kshada Kasa. I may tell that in the case of an aspiration pneumonia, all these Samprapti work under the framework of Rajyakshma. Think about the Egadasi Rupa of Rajyakshma. Pinasa, Swasa, Kasa, Amsa, Murtha, Swaradijo, Ariji. Urthvam, Brithamsha Samshoshavadha, Chardischa Kostage, Tiryakste, Parsharu, Doshe, Sandige, Bhavadi Jwaraha, Rubani, Egadashedani, Jayande, Rajyakshminaha. So, the Egadasi Rupa of Rajyakshma scaffolds all into one plane. That means when Rajyakshma Egadasi Rupa happens, it includes the Jwara Samprapti, it includes the Kshadakasa Samprapti, everything. So we have to operate this type of influenza, pneumonia, etc. by becoming more resourceful. In that way, we have to select our medicines from the context of Jwara, from the context of Kshadakasa, from the context of Rajyakshma, and bring the patient back to life. Also, we have to focus on the Hridaya Marma Abhigadam, Uro Abhigadam, etc. So, what are factors that can protect that particular areas that can also be instituted?